Okay, guys. Good evening. I am Pradnya here, and today we're gonna start something that we had long been discussing: creating awareness about pain education. And we had an inaugural seminar about the Pain Collective, which is a musculoskeletal pain support group, which Positive Physiotherapy has now started. Okay, the main intent of Pain Collective is to create as much awareness amongst the clinicians, academicians, students, and the patients about the modern concepts of pain science. And as the first step towards educating the clinicians and physios and the students, we are starting a series of these three webinars through the Pain Collective. And the first topic of that webinar today is about patient communication. Okay, the skill of asking the right questions to your patients and thus getting the right answers from them, which will help you in getting the right treatment outcome for your patients. Okay, now many of us asked actually after we had posted about the Pain Collective on 29th, what exactly are we here to do and what is going to be the exact outcome? What activities are we planning to do through Pain Collective? Okay, so Pain Collective here is basically to help connect the clinicians, patients, and academicians on one platform to bring in a conceptual change. What do you mean by conceptual change? To bring in a change which is going to help us understand more about musculoskeletal pain and help us deal with it. Okay. So it is here to help people with musculoskeletal pain to make sense of their pain. Many a times these patients are lost. They are confused because they don't understand what exactly has to be done to manage the pain. Okay. We want to empower all of you, including the patients, with the right set of knowledge which is required to manage musculoskeletal pain, and then to connect people to help form a community of such like-minded people, which would be empowered to further spread the awareness. So when we are taking these the Pain Collective educational seminars, the intent of this is, at least after attending these seminars, you guys go out and create awareness within your community, your colleges, your residential areas, and then let us know that you've conducted such and such activity for your patients or for your college. Okay. The main intent is the message of pain awareness has to spread to all the people. Okay. So that is why we are doing these seminars here. Just like fine. So why what we discussed, we had the inaugural seminar of Pain Collective on 29th of January, and we dived deep into the pain physiology and mechanisms. I am just brushing through few of the important points of that session. But for all of you, those who are interested, can join the Pain Collective Educator Program group, and then we will be sharing these presentations and articles there. But to cover it up in a gist, what we discussed was about how A delta and C fibers are primarily the report guides. They help you detect even the smallest change within the system, and they report it to the brain. They report it to the dorsal horn. Okay. These fibers do not just transmit pain. Okay. They are report and support guides, as I have written down there. And almost 35% of these fibers are active all the time. Okay. They are active even at rest. Then we discussed about nociception. Now, to just make a clear point, nociception and pain are two different things. They are not same. We have been trained to believe that nociception is equivalent to pain, or pain is equivalent to nociception. But under nociception, we have three types of pains, which are your ischemic pain, which is something what McKenzie has always been described as a postural pain. You sit for a long hour of time, then your neck starts hurting or your back starts hurting. That's an ischemic pain which asks you that it's time to move. Then you have something called as an inflammatory pain, which we all are aware can be traumatic or non-traumatic. An ankle sprain is an example of inflammatory pain. Then we had also discussed about the neuropathic pain, wherein you have neuropathic pain is something which does not comes in zincs and zaps and is neurogenic in origin. Okay, we had then gone into details of what do you mean by primary and secondary hyperalgesia. That is a state of sensitization which can be primary or peripheral or central sensitization. Sensitization is a condition wherein the patient is uh, responsive to pain all the time. The person feels that there is danger and the brain is always sensitized. There is no typical pattern for the pain, and the pain starts behaving unpredictable. You see the person today and the person responds to your therapy. Tomorrow, when the same person comes to you, he comes up with sudden increase in pain. You have not even touched the patient and you just tell him to move the hand up and down, and the movement, a simple movement which he's been doing, starts giving him pain. So sensitization is basically your brain's survival mode has been activated because the brain is sensing danger everywhere. And to protect you from danger, the brain starts to be in a super active mode, hyper alert mode, we call it. So it's a warning system which has gone overboard. Then we discussed about DIMS and SIMS. DIMS means danger in me, and SIMS is safety in me. These are certain categories which have been put forth by Lorimer, Mosley, and Butler, which actually helps you define pain. Okay, because we now know that pain is not just a sensation which is related from a tissue point of injury to the brain. Pain is actually influenced by the people in our life, the places you go. So if you have, for example, you are going for an investigation for a low back pain, and you meet somebody there who says, I had similar complaints, and the doctor said the disc has bulged out, and I was put on bed rest for 6 months, and then I just couldn't get back to my routine life. This person, the place you went was an investigation department. The person you met there increased your danger signals, increased the threat, increased your fears about the pain. So that is danger in me. Whereas you go to a physiotherapist with your MRI report and she counsels you in such a nice way that the disc probably has an issue, is irritable right now, but adequate amount of rest or a good management in terms of exercises, which we gradually do, are going to help you. This particular person is a safety point for you. This particular person is encouraging your brain to believe that a disc pain or a low back pain is not so dangerous as it is thought. So this person is a safety in you. So likewise, you have things which you see, people you interact with, places you visit, your thoughts and your attitudes, which can be dangerous for your brain or which can be triggering safety for you. These were the points that we discussed, and then we came on to a very good model of for assessing and analyzing musculoskeletal pain, which was a load capacity model. Now, what this says, this model goes on to encourage that you will get pain whenever you exceed the capacity of your body. Whenever the load, the amount of stress that you put onto your body exceeds its given capacity. So, if you are, let's say, an IT operator, a person who's just doing a sitting desk job. So your body is programmed for sitting 8 to 9 hours and may not give you any problems when you manage to do that work. But all of a sudden you decide that I want to participate in the marathon and I start running. But before running, I'm not actually preparing my body for that kind of activity. And I move on to load my body beyond its probable capacity. So say I run 5 to 6 kilometers on the first day. Of course, my legs probably might hurt, my back might give me pain. So that is exceeding the capacity. If you put your musculoskeletal patients into this load capacity model and try and explain them their pain, it becomes a very helpful analogy. So this is what we know of pain as of now in through the modern pain science concepts. Now, in a nutshell, what I would like to summarize pain as, it's a very complex multifactorial phenomenon which is unique to each individual. Your low back pain, my low back pain is going to be different. Okay, if you take people of two similar age groups, so a 20-year-old female, two 20-year-old females with carpal tunnel syndromes, their presentations, their symptoms, their um, the intensity at which they are presenting to you with pain are going to be different. So, pain is the lived experience which every individual experiences, and it is unique to that particular person. It is a real experience. Okay. It largely depends on the context in which it is happening. So, likewise, we always have seen that if we have to quote an example, the best example is of the players playing on during a match. So, if you see any particular athlete who gets injured, he is not going to leave the game if he's on a winning note. Okay, so it depends on the context. At that particular moment, for that player, the game is more important. So the brain shuts down the pain mechanisms, pain producing switch on and off रहता है जिसको हम लोग बोलते हैं. So the switch off mechanism is turned on, and the person is able to go through the game entirely. He might collapse after the game. Okay. But important is that given that given context, the person was able to uh, finish the game. Okay. Am I audible to everyone?
Yes, yes, ma'am.
Okay. And it is largely dependent, as we saw in Sims and Dims, it is largely dependent on an individual's beliefs and attitudes. So if I believe that my frozen shoulder is never going to get better, it will not get better. And if I believe that even though I have pain going down my leg from my low back, but if I take due care, if I take adequate rest, and if I manage it well without creating a panic around it, I will get better. Okay. So individuals' beliefs and attitudes are very important. And when we've long been talking about, using a biopsychosocial framework for our pain, understanding pain, because we call it as an experience, which is influenced by the biological structures, the psychological framework of the person, as well as the societal influences. So when we talk about any condition which is so very much influenced by the biopsychosocial framework, having an effective communication skill is very important for you as a clinician, and which is why we thought that let us keep this as the first topic, wherein we understand how do we go about communicating with our pain patients. Now, while we always end up asking this, I guess in your final years in ethics, you final year students have ethics as a topic, and you have communication skills and bedside manners as one of the topics. Okay, why do you think this is important? Now, this is one example wherein the person goes to the doctor and says that I broke my arm in three places, and the doctor says, well, don't go to those places. This is just one of the posts that I've taken from Google, but I actually had an orthopedic telling a patient of low back pain, when the patient went to him, like, sir, I cannot get sleep after 3 a.m. I wake up because of my pain. And the surgeon said, then you should not sleep after 3 a.m. Okay. Now, jokes apart, but the person is in distress, the person is stressed out, the person is confused, has come to you for help. And if you cannot understand those problems, then you will not be able to help. Forget about helping the person, but what you are doing is you are impacting their pain. Your words have a lot of power to influence the person in a positive or a negative way. So, as a therapist who comes into contact with the person much more frequently than what an orthopedic or a physician would come in contact, I think the words that we use, the way we communicate is very, very important for our patients to get better. Okay, which is the reason having effective communication and empathy will help you go a long run when you are seeing patients with musculoskeletal pain. Now, what needs to change? As we discussed in the physiology aspect, the understanding of pain has changed. We are now not dealing with कि यहाँ पे इंजुरी हुआ तो यहाँ से इंजुरी is being transmitted to my dorsal horn, which becomes my first order neuron. From dorsal horn is going up to the thalamus, and thalamus से एक specific center in the brain which is giving me the sensation of pain. No, now we understand that there is something called as sensitization, which physiologically is a state of over alertness. Okay, so that cannot be covered in your normal history. So the way we take history, the way we try and talk to our patients and ask questions has to change. There has to be a different way to seek clarity about the dangers and the safety that the person feels. Okay, the person has already come to you with a baggage of information wherein the doctor has said probably back pain hai ya knee pain hai, so you will not sit down. You've already got high level of osteoarthritis. There has to be a way to assess these fears, their beliefs. Okay. And what was highlighted to me when I did ACE ka, function first pain ka course was the influence of non-verbal communications. And then they also help me understand what are the relevant questions which you would like to ask your patients without offending them. They're in a vulnerable state when they come to you. So you don't want to be a barrier to your patient. What I want to hit here is you guys have to understand that majority of these symptoms, like they come to you, the DIMS, SIMS are invisible. Their sensitization is real, their pain is real, but majority of these things are invisible, but they are not imaginary for the person. The person is actually experiencing it. Okay. So the things which have to change is the way you look at your patient, the way you deal with the history, trying to get the information, and about your non-verbal communications. I'm not going to go in depth of the non-verbal communications, but the major important aspects of your non-verbal communications. What do you do whenever a patient is just entering your clinic? Okay. Do you welcome them with a smile? Yeah, are you very empathetic in your approach, your body language, is it welcoming? So if I am not even making an eye contact with my patient while I am talking, that gives them the feeling that I am probably not interested or not listening to what the person is trying to say. Eye contact is very effective way of establishing a rapport with your patient. It is very crucial that you have an understanding expression on your face. So the person is trying to, tell his history, trying to connect with you, and you are looking here and there, or you are just engrossed into your phone, not even looking up to what he's saying, or probably you're sitting with your hands folded, which like I'm not going to go in details of body language, but most of the times we know that if I lean forward and sit here with an expression, I am nodding my head every time and again, that gives my patient the trust, the confidence to talk. These people are not going to open up to you in the very first meeting, and especially if you are not even giving positive signals through your non-verbal communication, it's gonna affect their confidence and their ability to trust you. Put yourselves in their shoes and understand that if you go and visit a surgeon, so supposedly it's your bypass which is being planned, and your surgeon is not even looking at you and talking, how bad you would feel. You would be insecure. So having good eye contact, understanding facial expressions, and an open body language which makes them comfortable is the first and prime most important factor before you even start your direct communications with the patients. So even before we hit on to what exactly we want to ask our patients, what is important is you have to be purposeful in your questioning. you know uh, I have many a times patients, US students, who start the history is, person had fallen 20 years back and is now complaining of pain in the same left shoulder. Is it relevant? Okay. So your questions have to be purposeful. How purposeful? We'll get into details of that. But what is more important is, having an invitational tone to your questions because they're better understood and better responded by your patients. So, if just for an example, which is non-medical, if your child comes back from the school and you just ask him, "How was your day?" he would end up saying nice or bad. Probably the teacher shouted at him. He would just say bad. Okay. You're not going to get any insight into how the day was actually spent. Against that, can I be more specific and open in my questioning, wherein I say, tell me the most exciting thing that you did today? Or if I see that the child has a fallen, sunken face, I know the day was bad. So I can just ask, can you tell me what disturbed you today the most? So, invitational questions are questions which help them understand that they are supposed to describe the event. Okay. So, in terms of your pain, can you tell me the first experience of your pain? How did it happen? Or how are you exactly feeling right now? What is the feeling? Okay. Describe your feeling. So that helps them communicate better. Now, we're going to share a handout to you wherein all these types of questions have been enumerated with examples. But there are these many, I have enlisted four types of questions here, and I'll quickly go through them, what they actually mean. The fifth one, which is our favorite and which we use a lot in our clinical practice with almost every patient of ours, we'll discuss that in detail. Now, why do you need to know the art of questioning? Because it helps you gain an understanding to your patient's mindset, helps you to achieve better answers and build good relations. I said a rapport building is the first thing that you will need to do with people with with pain. Okay, and if you are not to the point, if you are not able to get an entry into the person's mindset, then you might just become a barrier for that patient. What do I mean by barrier? You might be just increasing danger in me wala signals. Acha, disc hai. Your doctor has said it's disc. So that means it's probably hitting onto the nerve. So are you getting tingling going down the leg? Usko nahi bhi ho raha hoga na, so he will just start focusing ki yes, I have pain here and it's probably going down my leg. You are then increasing these difficult thoughts for them. Okay. So questioning is an art. What you need to do is avoid asking too many questions to these people. Let them understand that what you are trying to do is just not just getting information, but trying to establish a connection with them. So do not frustrate them with too many questions. Okay. So what are close-ended questions? Now, close-ended questions are, as we saw on the previous slide, how was your day? Okay. How was your day? Bola to, what do you say? It was good or it was bad? Where is the pain? So these questions are icebreakers. Okay, they just give you clarity. Where is the pain? How much does it hurt? Are you able to sit? So these are your close-ended questions. Your open-ended questions are like the invitational questions, which are client-centered, patient-centered. So could you share your experience of the pain? How are you exactly feeling? Okay, that those are your open-ended questions. They help you get an entry point into the patient's mindset. Reflective questions are something which will make them think about the entire experience of pain. Patients are probably these persistent musculoskeletal pain patients are there, are having pain for almost 5 to 10 years majority of the times. So ask them straight away, like, what change do you think this pain has brought into your life, or this specific problem has caused? They start reflecting, they start analyzing internally. So they try to take control. Reflective questions are very good when you want your patients to start taking control of their pain. The last one is Socratic questions, which is usually reserved during for the when the person is coming towards the end of your sessions, like when you are about to discharge the patient, which is basically connected with critical thinking. So questions such as, what do you know now about your pain which you didn't know before? So like पहले उसको पता ही नहीं था कि sensitization या the people around me can be danger or can be safety. I can have a safety net with certain people. My pain can be triggered by lack of sleep or stress. All of these things the person was not aware of. So Socratic questioning is a way of enhancing the critical thinking. We're gonna give you the handouts of this on the drive. Now, what you need to do is the questioning, as I said, is meant to reassure the patient that the person is in good hands. So, to effectively reassure, you need to understand what is it that is concerning the person. Okay, they are not going to tell you directly. No person is going to come and say, "Ki boss, my back pain is troubling me a lot, and because of which I'm not able to go to work, and I'm in a financial crisis." No. So, what you need to do is ask certain patient centered questions. What we usually do, me and Yuvraj in our clinics, is this. Whenever we see the person, they are going to come with multiple problems. Many a times the pain keeps changing their locations and fluctuates. So, what's the most important thing you want me to help with today? Let them decide. You do not say ki you have come to me with back pain and I am going to treat only your back. The person might just next day say ki, my back feels a bit better, but it's probably my buttock which is hurting or which is giving me an uncomfortable sensation. The second most important thing, what helps you to probe into their belief and attitudes is what according to you has caused this problem. So when they come to you with pain, you have to try and analyze what are they thinking? What is the cause of problem? If they think that, sleeping on a hard mattress has caused me this problem, then you have the probable solution. You may not even need to go through your IFTs and taping and all of those things. A good amount of education would just help and certain movement advice might help. Okay. There are few more questions like what concerns you the most about your problem? Do you have any major concerns that you would like to talk to me about? Or what's your biggest fear? These questions we call them as the belief questionnaire. What they do, they help you understand the mindset of the person. As we discussed, pain is an experience. You have to understand what's going on in their mind for you to get a better treatment outcome. So, what happens is when you're questioning, how is your tone? What is the context? What is your body language are very important. Therapists should work as guides, okay, and not work to change their mind. Please do not try to invalidate their thought processes. You are there to help them. Be be not judgmental. Let us not be judgmental about their condition or their thoughts. So even if they think that this probably has some we had in Panvel in MGM when we were there, people believe that their pain is because of bad blood in their body. So if they believe that, no amount of exercise is going to change their strategy. A good amount of education might help. So do not work to invalidate their beliefs. Okay, that might just lead to more anxiety and more catastrophizing behaviors in them and create more uncertainty. This is very important, which I usually answer my patients. And I feel that patients would generally like to know what is this pain. So we discussed this in term pain mechanisms. What is this pain? Is this ischemic, inflammatory? What must have caused this pain? Okay, can you come up to a specific reason? Is there anything damaged within me? Or is it my working hours or my lifestyle that is causing this pain? What are the consequences? What will happen if this pain persists? So, going back, what are your biggest fears in the previous slide and what are the consequences? Will help you understand. So, if the biggest fear is my back pain is never going to allow me to get back to my routine life, the consequences are going to be bad for him. Okay, this is how you relate, and this is how you then chalk out a program for your patient. How well can I control this pain? The person wants to control the pain. If you see, the locus of control here is not with the therapist, but it's with the patient. And how long will this last? So if you know that it's a tendinopathy or tendinitis that the person has come to me with, max to max 3-4 hafte, 6 weeks is what it takes for a tendon to heal. You should be thorough with your physiology knowledge. Okay. So these are specific questions which a person might just want to know. So remember, you can never completely understand or explain anybody else's pain. As I said, it's a unique experience for that person. The person is an expert in their pain. So please allow them to lead. If they say, Ki Mala, I know what is going to help me manage this better, Many a times, please don't be afraid to let the person leave. Use their conceptualizations, use their understanding of pain. It absolutely at the end has to be an alliance between you and the patient, and not a dictatorship or a didactic lecture that you're giving that the person has to listen to you. Okay. To summarize, always listen. We discussed the art of asking questions and what are the right questions you might want to know. But what is important is also listening to the person. Listen and validate. Ask open questions. We've given you a type of questions that you can be asking, and explore their beliefs and valued activities. What is it that the person wants to go back to? Okay, not what you can be able to make the person go back to. So if it's a 70-year-old granny who comes to me with OME and says that my only expectation is I should be able to go to a temple which is 10 minutes away, that is her valued activity. Okay, and I should program my rehab in such a way that I am able to take the person back. Always be encouraging, motivating, and reassuring for your patient. That's what majority of these pain patients actually need more than any sessions of IFTs or modalities to help them get out of this. Okay. So this was it about the effective communication. The meeting would actually end, but if you guys have any more questions, we can rejoin using the same link. Yeah. But in a nutshell, understand your patient, understand that the pain has many other factors through which it can be influenced. And if you want to be a good therapist, communicating with the person, understand what are the non-verbal cues that you are giving, and also reflect upon the type of questions that you are trying to ask your patients. Yeah. Any questions, guys? So we have also made a group, the TTC educator group. If any one of you has joined not from
Hello.
that group, then I would like you guys to send me a WhatsApp message, and I'll add you to that group so that whatever links and material we are sharing, it will be available to you. Fine?
Hello.
Yeah,
Hello. Madam,
yeah,
I'm Dr. Vaibhav from All India Institute.
yeah. Tell me, sir.
Yeah, I no nothing. I just little my Zoom this app was not there, but initial part I just missed. But I joined later on. I understood what your topic about the pain, and I also told all my students are also there online. All the four
That's very
students are MSK students are there. They are